important is, of course, to measure calcium levels. Some clinics can measure ionized calcium, and some others measure total albumin corrected calcium. There are some studies that have suggested that the total calcium is better than the albumin corrected due to some of the calculations behind. So we have discussed in our group and would suggest that ionized calcium is best if possible, but otherwise you can measure by total calcium levels. In a well-controlled patients in a steady state without dose adjustments, we would recommend to measure calcium levels every 3 to 6 months. It's another thing if the patient needs adjustment of dose, then it's very important to measure it much more often until a new steady state has been reached. If the patient has hypercalcemia, then it's very important to follow the kidney function, because the kidney can be damaged during hypercalcemic episodes. So when trying to find a new dose, it's important to follow the kidney function closely. When we're increasing active vitamin D analogs in case of hypocalcemia, then it's important to remember that it takes often 3 to 4 days to see the effect of the increased dose. So you have to follow the patient close for a bit of time until you know they're in a new steady state. If the patients have current illness, dehydrated, pregnancy or lactation, it is also important to measure the calcium levels more often than every 3 to 6 months. When doing biochemistry checkups performed every 3 to 6 months, it's also important to include phosphate in order to avoid hypophosphatemia, and creatinine to monitor kidney function. On an approximately yearly basis, it will also be preferable to measure serum magnesium to make sure that the levels are within the normal reference range, or if they are low, and then to substitute it. Also, vitamin D levels needs to be normal in patients with hypoparathyroidism. A more discussed thing is how often we should measure 24-hour urinary calcium excretion in these patients, because we need to be aware that these patients can have hypocalciuria. So we would suggest that we measure them every 6 to 12 months with a 24-hour urinary collection, but if the patients are in a steady state and they do not have hypercalciuria, it could probably be every 12 months. In a case that the patient is known with kidney stones or calcification, it could be supplemented with measurements of excretion of sodium, urea, citrate, oxalate, urate, and other analyses like pH and osmolarity. If the patients are on PTH treatment, then it's recommendable to measure bone markers once in a while during the treatment, because we know that PTH treatment will increase the bone markers to a very high extent.